Thanks everybody for coming today. I really appreciate your interest in patient advocacy. My name is Julie Grimstad. I have served as a patient advocate for vulnerable patients for over 33 years. And currently I serve as the board president of the Healthcare Advocacy and Leadership Organization, HALO for short. It's a brand new organization, and we're very excited about it because we're going to expand our mission. Whether or not you decide to volunteer as a patient advocate, the information you're going to receive today is very important. Just if you have a loved one who goes into a healthcare facility or any healthcare setting, you'll need to know this information. It's always wise to be prepared ahead of time rather than being surprised by some of the things that you will find that are threats in our healthcare system. Because our healthcare system can't always be trusted to provide safe havens for people. We trust our healthcare providers, but they can't always be trusted. And sometimes they don't tell us the truth. And we have to know how to discern the difference between a healthcare provider who's telling us the truth and one who isn't. How does HALO define patient advocate? We define it as someone who has an undivided interest in protecting the welfare of a vulnerable patient in a healthcare setting. So a person who's a paid patient advocate by a healthcare facility, for instance, may have a conflict of interest. Of course, they can help educate the patient and give them some options. They can also mediate in certain conflicts. But when push comes to shove and they have a choice to make between doing what their employer wants them to do and serving the needs of the patient, what are they going to do? Some choose to do what their employer wants them to do, while others defend the rights of their patients. And sometimes they get in trouble for doing that. What we need to always remember is that doctors and nurses are not our enemy. Many of them are there to serve us completely, and we can trust them completely. But we need to know how to discern the difference. So we're going to cover some of those ways of discovering who's a good doctor and a good nurse and who isn't, and how to protect ourselves. I've known a lot of nurses and doctors who've sacrificed their jobs and even had their careers threatened because they put their patients' interests ahead of what the facility they worked for or the HMO they worked for. For some patients, a patient advocate is their last friend. And a patient advocate can be anyone. It can be a relative, a friend, a volunteer, or someone on their healthcare team who's really looking out for their good. The first time I became a patient advocate, it was by accident. I didn't know I was going to do this, but my next door neighbor across the street, her name was Jane. She was 92 years old. She was fit as a fiddle, as she put it. She was an old Montana rancher. She walked several miles a day in the hills of Montana, and she was an absolutely sharp lady. She got a kidney infection. I convinced her to go to the hospital, even though she'd never been in the hospital in her life, and she was terrified. Well, the first couple of days things went well. They were getting her over her kidney infection, but she got a little agitated and scared at night. And so they gave her a medication called Haldol. Haldol is an antipsychotic, an anti-anxiety drug, but it has a bad side effect in some elderly people. It can paralyze the muscles in their neck or their throat. And Jane lost her ability to swallow. And so over a period of a few days, I noticed that she wasn't eating. And I would try to feed her ice cream and she couldn't swallow it. So I went to the pharmacist, my personal pharmacist, and I asked him, what's wrong? Here's her list of medications, what's wrong? And he says, it's the Haldol. He says, that is what is causing her difficulty swallowing, probably because it can have this effect in some people. So we went to the doctor, her daughter, who was in her 70s, and I went to the doctor and said, please take her off of the Haldol. This was what the pharmacist says. And he wouldn't do it. He said, if you don't trust me as her doctor, go find another one. So we did. And Jane survived and was home in a few days, but the doctor matched her up with a speech therapist to teach her how to swallow again. So that was a surprise to me. I was an LPN, a licensed practical nurse, but I did not know what to do in a circumstance like that because I was taken totally by surprise that a doctor could be so careless with a human life. And that really woke me up. A couple of other incidents that same year, that was back in 1985, really woke me up. And I don't have time to tell all of my experiences today, but that one was the first. Regardless of how you become a patient advocate, it's wise to be prepared ahead of time. We need to recognize what's going on and take quick life-saving action. People in that situation do not have a lot of time. Regardless of who you're taking care of, whether it is a relative or whether the family has called you in, or it's somebody at your church, or it's just you're visiting someone in the hospital and you happen to see something you don't like, neglect and abuse should be reported. And things that you think are life-threatening should be reported immediately. You can go to the nursing supervisor. If you don't get a response there, you can go all the way up to the state ombudsman, and there are a lot of other places that you can go to report this kind of thing. But sometimes the reports take a little while, and meanwhile this person's life is in danger. I have had circumstances where I've seen something going on in a nursing home, and I've reported it and nothing was done, and so I've sat there and waited for a relative or someone to come so I could explain to them what I saw. We need to do these things. We need to be responsible for each other. Regardless, again, of how you become a patient advocate or who you are a patient advocate for, you have to realize there are many aspects to patient advocacy. Some patient advocates just simply answer a telephone or educate other people. You educate yourself and then you go out and educate other people so they're prepared. That's an aspect of patient advocacy. We are trying to set up a 24/7 hotline. We need volunteers to answer the phone. Of course, we'll train you. We'll answer your questions, and we have many resources available to you so that you're not sort of left out in the dark to answer phones without knowing what to do. We also accompany patients and their families, especially when they're in a healthcare setting. A patient advocate at the bedside can be very comforting to a patient and a family because they don't know much of anything that's going on. They're anxious, they're frightened, and our caring presence can make all the difference in the world to them. We have eyes to see. We're not as emotionally involved with this patient. So those are things that we do. We also can accompany a patient advocate to the doctor's office and facilitate communication with the patient advocate. With the doctor and between the patient and the doctor. I had a patient one time who had prostate cancer, and I would take Jay to his appointments at the vet hospital. And we would get there and wait maybe 2 hours or more in the waiting room waiting to see the doctor. And during that time, we would compile a list of questions and concerns and symptoms so that when we got to see the doctor, we could address all of his concerns in one visit. And when we would get into the doctor's office, the doctor was in a hurry because he had so many other patients to see, and he was already behind schedule. And he was this particular doctor was from India, and Jay could not understand what he was saying. And so I could interpret, I could ask the questions, get the answers, But the doctor was in such a hurry that I would casually stand in front of the door so he couldn't escape while we addressed all of the questions. And Jay was very appreciative, the doctor not so much, but it was an experience where I learned a great deal about how to get what you want in the healthcare system. And one of the things I learned about elderly people is a lot of them don't hear well, or they don't see well, or they don't communicate well, and they're not very forceful sometimes. Some of us elderly people are very forceful, I'm finding out, because I'm one. But some elderly people are timid about confronting their doctor. And because they were raised in an environment where they could trust every doctor, or they felt that they could, they are very trusting. And they don't suspect when something is not quite right. Sometimes immediate help is needed, and when you're on the phone call, you can direct this person to the appropriate lawyer or doctor or other help that they need. One case was the Life Legal Defense Foundation got a call, and it was the case of a 93-year-old woman. Her daughter called. They were denying her food and fluids in a hospital in California. She was dying of dehydration. Immediately, Life Legal Defense filed court pleadings demanding that the woman receive proper care and a temporary restraining order prohibiting the hospital from killing the woman. Life Legal Defense was successful, and the woman survived, even though she'd been without food and water for 3 days and was near death when they intervened. But their immediate action when the daughter called made the difference between life and death for this woman. This woman was not terminally ill. She was breathing on her own. The hospital decided it was within their rights to decide that she was better off dead, simply because she was elderly. Sometimes when we accompany a patient or the family through a healthcare crisis or through a long-term situation, this is a real commitment. I've had people that I've been involved with for 6 years, and sometimes I've had to, when I've moved from one place to another, I've had to turn them over to another patient advocate. But sometimes it can be a very long-term commitment. You don't have to commit yourself to that kind of patient advocacy. Everybody can do some aspect of patient advocacy. I want to tell you about some of the things that I do when I accompany a patient in a hospital. First of all, I make sure that if they're able to swallow and eat, that they get their meals. Do you know that in a nursing home or a hospital, sometimes they'll just come in and leave the tray, and the person will not be fed, and they'll come and they'll pick up the tray, and nothing has been touched. But there was no staff that could help them eat because they're understaffed sometimes. And if a relative or a patient advocate or someone isn't there to help with meals and make sure they get adequate hydration, the person could die just from dehydration within a matter of days. We also can be there to comfort the patient so they're not pulling on tubes or whatever, depending on the patient's condition. We can also relieve the family. Occasionally they might want to go to lunch or out to shop or just take a nap. And if they don't feel safe leaving their loved one, they can't relax and they get more and more anxious and tired. And they burn out. And that's when they say, oh, what's the use? Let's just give up. A patient advocate is a real lifeline, tossed to not just the patient, but to the family. For people who can't speak for themselves, these are really dangerous times. They're frightened. I go to the nursing home sometimes and a patient with dementia is really disturbed because someone took something from her room. And the staff will say, oh, she's just confused. And I'll say, no, I saw the dolls on her bed last week and they're missing this week. And she knows that they're gone. Where did they go? And sometimes we can track them down and sometimes we can't. But that's another aspect of patient advocacy. We can steer patient and family decisions to the right decisions. Sometimes, if you have a biased clinician, they will try to steer the patient towards refusal of treatment that could be life-sustaining. What we do is we try to help the family discern what the patient really wants and what's available and what will help the patient, and to get some honest answers from the healthcare professionals that they're dealing with so that they can make informed decisions. Don't be fooled, however, when a healthcare provider says something like, well, we can take away food and water, it's not painful, it's a natural way to die, or it's an ethical way to time the end of life. Those are all lies. Some people believe them who are saying them because that's what they've been taught, but it's not true. An experienced physician with common sense told me that, quote, anyone who has been moderately to severely dehydrated has probably experienced stinging eyes, dry skin, burning urine, and pain with swallowing. Well, I can tell you that when an elderly patient or a very sick person is denied food and fluids in order to control the time of their death, not when it's medically appropriate to do so, they experience similar symptoms to what the doctor described and even worse. I have seen people actually bleeding from their nose because they've been deprived of food and fluids and things started to dry out. It's not a pretty sight, and I feel sorry for the healthcare providers who have to preside over this kind of a death. But it's very common today to see this happen. Comfort care is sometimes code for depriving a person of food and fluids and sedating them or giving them pain medication to keep them comfortable. We have to watch out for that. They will often tell us that, especially in a hospice situation, we've been told that the person is showing the signs of approaching death. And what they're actually doing is they're making the person die. And those symptoms are very much like the symptoms that you would see if someone was truly near death from natural causes. And so they do what we call stealth euthanasia, which is hidden euthanasia. They tell the family, oh, they need pain control, they need sedation, and then they take away their food and water and the person's dead in a couple of days or a week or two. We know that if a person lives very long after they do that they weren't near death. They were starved and dehydrated to death. But that's an after-the-fact knowledge. Our greatest challenge is to prevent patients from being euthanized. A doctor with whom I wrote an article on stealth euthanasia recounted what a nurse had told him. She said, a doctor admitted a patient with a painful metastatic prostate cancer, and then he verbally directed her to warp him out of existence, warp him out of the world. She informed the doctor that she and the other nurses would do what they could to provide appropriate care for the patient, but they would not kill him. And the doctor insisted that the patient not be alive in the morning. However, the nurses did what they do. They relieved the person's suffering and they took appropriate care, and in the morning he was still alive when the doctor showed up. So it's important to distinguish, though, euthanasia from legitimate decisions to stop treatment or to give pain medication. The intention or effect must always be never to kill the patient, okay? So whatever you do, you should not intend to kill. Many of us have had experiences with our own families where we think that maybe they were rushed to die, or they were actually killed outright when they might have had many years to live. We were told the wrong thing. We were unaware of what was going on. We cannot hold ourselves responsible or feel guilty for not knowing what was going on. What we can do is educate ourselves so we can help other people to know what's going on. And we don't want to scare people because there are some good nurses and doctors. We have tools for determining which doctors and nurses are really interested in the patient's life. Families who go along with what doctors want them to do, even when it's not the right thing to do, they are usually very anxious, they're exhausted, and they are very concerned about the patient's comfort. So they listen to the doctor, they take their advice, and it may be the wrong decision, but they didn't know it at the time. And we have people call us who are beating themselves up once the funeral's over and they are feeling like something wasn't quite right and they should have recognized it. And we really have to help them with those emotions and help them to see that they were not told the truth at the time. So now we have the opportunity to educate other people with what we've learned here today and what we've learned in our own personal experiences. One of the most important skills that I have to emphasize for a patient advocate is listening. We have to listen to the patient and to the family. We have to listen to them with respect and with empathy and with patience. Patience is the hardest thing. Just listening takes a lot of patience, especially some people are so distraught that they repeat themselves over and over and over and over again. They just want to get it all out. And so you listen. But the equally important is listening to what the healthcare providers are saying in their words and their actions. Do they treat the patient and the family with respect? Do they listen with respect? Do they give them honest and sufficient information to make informed decisions? Are they pressuring the family unduly to stop treatment? Do they use words to describe the patient that are dehumanizing, such as a vegetable or vegetative or a waste of resources or a life not worth living? Or I wouldn't want to live like that, extrapolating from their own feelings what someone in that condition might feel like, even though they have no clue what that patient really wants. And he should rely, the doctor or the nurse should always rely on what the family says, unless they think the decision the family is making is wrong. And then they can gently try to persuade the family that this would be appropriate treatment. Nancy Valco, who's an RN who works with us, has been very involved in patient advocacy for a long time. She was an ICU nurse. She has worked in hospice. She has a lot of experience, and right now she's a nurse consultant. She's retired. She was in nursing for over 40 years. She said, she gives us this account. She has lots of accounts of things that have happened in the hospital, some of them wonderful and some of them not. She said, I witnessed a fully conscious man with Alzheimer following a bout of pneumonia be deprived of a feeding tube after his breathing tube was removed. As a result, he was not given his blood pressure medicine, which caused his blood pressure to go sky high, and he soon died of a stroke. I was there when the neurologist examined him, she said. The family was considering a feeding tube because the man couldn't swallow because his throat was irritated from the breathing tube that was removed. The doctor asked him questions which the man answered accurately. Then the doctor held up 3 fingers. He said, how many fingers? And the man shakily and slowly held up 3 fingers. The neurologist wrote an order, NPO, nothing by mouth. And Nancy said, why? And he said, he didn't raise his fingers fast enough. The family decided to go along with the doctor's recommendations. That's why the man died. Not because he was terminally ill, but because his doctor thought he was too slow. Patient advocates need to understand that words used in the healthcare setting often don't mean what you think they mean. So even if you're filling out an advance directive for healthcare, you need to be aware of the words that are used in there. They all have legal meanings, but they also have medical usages that may not be what you think they mean. Comfort care, as I said, doesn't always mean that they're going to provide food and fluids. It means they might take away food and fluids and just keep them comfortable with pain medications and sedatives. So we have to watch the words that are used. That's why I don't like advance directives for healthcare that have blank lines in them that you can fill in yourself. You might use a word that's interpreted differently from how the healthcare team might interpret your wishes. As one good nurse explained, if a person needed their blood pressure and other medicine to live over the last 20 years, they still need it. Okay, no matter what their medical condition is, they still need their ordinary medications until the point when their body can no longer assimilate it, which is just before death, usually a few days before death. She said, it can't be very comfortable, as the man that Nancy described, to have your blood pressure shoot up and then stroke. Patients, families, and patient advocates need to explore the ethical principles of healthcare providers. When we're in a hospital situation, a lot of times we don't have a choice nowadays in who's going to take care of us, because it's going to be a hospitalist, a doctor who is employed by the hospital to take care of the patients who are in the hospital. And so it's not your own physician that you've known for years or that you've discussed all of these things with. It's somebody you don't know. If you're in there because you've had a stroke and you can't speak, you need to have someone to speak for you. And that is your agent under a durable power of attorney for healthcare, or a medical power of attorney. Not sure what it's called here in Minnesota. But the reason you need someone to speak for you is because if you can't speak for yourself, you're totally dependent on the healthcare team to make decisions for you. So when you're talking to your own personal physician, you can ask them some questions about their personal ethics. Do they understand that some treatments can be deemed burdensome, but that the patient's life is never burdensome? Do they realize that food and fluids, no matter how they're administered, are normal, basic care for every patient until they can no longer assimilate, until their organs start to shut down and they can't assimilate them, or there's some other reason, like an infected feeding tube, where they have to look for an alternative method to feed the patient. But you never give up on giving the person food and water. That's a basic necessity of life, and every single one of us would die within 14 days if we were deprived of fluids. And the starvation that goes along with it also causes a lot of suffering. So when a person is really close to death, it's sometimes appropriate to take away, to stop their food and water and just give them ice chips or little sips if they want to keep them comfortable. But otherwise, food and water are an absolute necessity. On our website, which we should have up soon, we will have this. It's called Principles for Medical Decision Making, Respecting the Value and Dignity of Human Life. And this particular document is a very helpful guide when you're talking to your healthcare proxy or agent about what you would or would not want. You can put this with your advance directive as, okay, this is how I want decisions made for my healthcare. And you can print it off the website, or we can print copies for you here for those of you who are present. Do they reject all justifications for intentionally causing the death of a patient? Okay, that's something you can ask your doctor. I've moved a lot in my life. My husband worked for the railroad, and every time I've gotten a new doctor, I've sat him down and interviewed him before I would sign up with them. But you can't do that in a hospital. So you have to be ever vigilant in a healthcare setting, a hospital or a nursing home, where you don't pick the physician that's taking care of you. There's a lot of information that I've presented here today, and you may want to watch this video more than once. There are many other critically important issues we could have covered today. We could have done a thorough explanation of advance directives for healthcare. We could have talked about do not resuscitate orders. We could have talked a lot about hospice and palliative care and what you might face in those situations and how to choose a good one. We could have talked about organ donation and brain death, but we're running out of time. So what we're going to do is we're going to have follow-up conference calls for those who have questions and are interested in continuing their education on patient advocacy. You can email us your questions at feedback@halorganization, halorganization.com, feedback@halorganization.com. Email us your questions and we will answer them. Also, please let us know if you'd like to volunteer with HALO as a patient advocate. Patient advocates must look at every human being as God sees them, not with our own limited vision. I know that when I was a nurse, a practicing nurse, there were patients I would have rather not taken care of. I wasn't looking at them through God's eyes. Now every time I walk into a hospital room or a patient's room, I try to look at them through God's eyes and say, this is a child of God. The attitude a patient advocate should have is beautifully stated by the noted ethicist Dr. Leon Kass, and I'm just going to read his quote because it's so beautiful. Life is something before which we stand, or should stand, with reverence, awe, and grave respect, because it is beyond us and unfathomable. To regard life as sacred means that it should not be violated, opposed, or destroyed, and positively that it should be protected, defended, and preserved. You can protect, defend, and preserve lives one person at a time. And one person at a time, you can educate yourself in how to be a patient advocate. Does anyone have any questions? Was she in hospice?
Yes, hospice at the hospital.
Okay, many times they do not provide, hospices don't provide IVs. Some do, the good ones do. So before you admit a person to a particular hospice, you should ask, do you provide feeding tubes and IVs? We have an entire list of questions that you should ask a hospice before enrolling someone in hospice. It's called Interviewing a Hospice Agency. Okay, it's in Informed, which is a publication that I wrote and edited, and there are a number of experts who wrote specific articles in here. Doctors who are involved in palliative care, nurses who are involved in hospice. So you will find this very interesting.
That she would drown then if they gave her stuff.
Well, if a person has congestive heart failure, then that may be true that they should not be given fluids. But then they should be given medications to drain the fluids, or the fluids should be drained physically, and then hydration reinstated. There are so many things that we are not told. And I'm not quite sure why we're not told them. I want to read to you something that Dr. Ezekiel Emanuel wrote in the American Journal of Medicine back in 1993. Now, Dr. Ezekiel Emanuel was the chief architect of Obamacare. And this is what he was saying back in 1993. He offered a solution to the cost of caring for patients who were not competent. Here's what he said, quote, "Increasingly, it will be our collective determination as to what lives are worth living that will decide how incompetent patients are treated." So in other words, they're going to collectively decide whose life is worth living and who gets medical treatment and who doesn't. And the reason that's important, we are on the brink of a geriatric crisis, old people. By the year 2030, it's predicted that 73% of the US population will be baby boomers. 73%. And a lot of us don't have enough children to take care of us. Then, if you think about it, by the year 2050, they're predicting that taking care of patients with dementia is going to cost $1.1 trillion. And that does not count the home care that people give. That's just professional care. That's a lot of money. Who's going to pay for it? And so they're looking for solutions now on how to limit treatment and how to convince people they don't want treatment. Any other questions?
This is just a comment. Recent experience I had with having my husband go to the emergency room, and discouragement from having him there and saying he should go home. And I told them, well, he's here now, why don't you take care of him? So I had to advocate for care after we had gone through the process. So.
And sometimes if a person has gone to the emergency room 2-3 times, they'll tell them, you shouldn't bring them back to the emergency room again. You know, yes, it's costing money. So we need to be patient advocates, as you were, for our loved ones, because when they get into a healthcare situation like that, they can't advocate for themselves. We need to protect them. And we also need to ally ourselves with the healthcare personnel there that are trying to do what is right for the patient. We need to make friends with them. When someone does something really nice for a patient that I'm taking care of, I make sure that I thank them. It's not just the gracious thing to do, but it encourages them to give this patient better treatment and to give other patients treatment because they're appreciated and we recognize what they're doing. So our gratitude for those who are doing what is right really encourages them. We should also protect their conscience rights. We should go to bat for them. Say they do something good for a patient and then they lose their job because the hospital didn't, and I've seen this happen. I had a nurse friend out in Washington who was fired from her job, who was taking care of her patients, 3 stroke patients, and they told her to stop feeding and hydrating them. And she and 7 other nurses refused to do that. And they were all fired. She decided to sue for discrimination. And she won her first round. She was awarded $100,000 by this one court, and they appealed it. Of course, healthcare facilities have a lot of money, and they appealed it, and they won the second time around. She was not only out of a career, but she was out of all the back pay that she would have gotten had they not taken away her settlement. These kinds of things do happen to healthcare providers, and in Canada, where medical aid in dying, where 99% of the people under their 2016 medical aid in dying law, 99% of the people who die under that law are given a lethal injection by a doctor or a nurse. And that's legal in Canada, all over Canada. When you look at that, the doctors and nurses who refuse to do that and refuse to refer patients, they're having a real difficult time in Canada right now. So we really need to defend the conscience rights of healthcare providers who are doing the right thing. Any other questions? Yes?
Well, nursing homes, again, my mother was in a nursing home. My dad ended up paying $5,000 a month for by the time in 2005, the year she died. And yet I had to be in there advocating constantly. It was in the 12 back there, and everybody else wasn't being taken care of. She had things stolen. She ended up having a broken hip, which she couldn't move, and that's how she died basically. But no matter how much your nursing home costs, it's so hard. We have to be advocates for other people there. People don't know what's going on in those nursing homes. I actually think that she was molested there too.
Mm-hmm.
So it makes me want to cry, thinking about these things. But we can't just trust that we're paying this money. Some people in there, their kids were in another state or something.
Mm-hmm.
So I would be like, well, so-and-so needs care, so-and-so. It's really scary.
Well, in Texas, I have a ministry called Befrienders. And Befrienders, we match up volunteers with one person in a nursing home, a team of 2 volunteers, adopt someone in a nursing home, or even maybe a shut-in in their own home, but it's usually someone in a nursing home. And they promise to visit them so that this person knows that someone is coming to see them every week. The nursing home also knows that someone is coming to visit this person every week. And they don't always go at the same time, so they don't know when they're going to drop in. And there's 2 of them. So maybe there'll be 2 or 3 visits a week to this person, this nursing home patient, resident. And that works very well. I get lots of reports of abuse and neglect. And we describe abuse as something that's intentional, that harms the patient. It can be stealing their money, or something from their room, or sexual molestation. It can be deprivation of food, or scolding them as though they were a child. All of those kinds of things come under the heading of abuse. Now there's neglect, and neglect can either be intentional or not intentional. For instance, maybe someone wasn't properly educated about how to turn a patient, or how to feed a patient, or how to gently get a person out of bed into the wheelchair. Those kinds of things may come under the category of neglect, but they're far from being abuse unless they're really intentional. For instance, I know that in one particular nursing home that I go in sometimes around noon to see who's eating, because they'll have them around a table, and I'll sit at the table and I'll encourage the ones who aren't eating very well, try a bite of this, it really looks good, but somebody's there encouraging them. That's not neglect or abuse on the part of the nursing home. Sometimes it's simply they don't have enough people to sit at every table. So we can be a big help just that way in making someone's life better, just by being there. We don't have to do anything really special. Just be there. Maybe paint their fingernails, or curl their hair, or makes their life happier. Loneliness is the biggest problem that most elderly people in nursing homes face. And if we can alleviate loneliness, we go a long way to giving people hope.